Today's topic is going to be imaging in genitourinary tuberculosis. So just let me know if the audio and video is fine so that I can kickstart the session. Okay, so understanding the pathogenesis, there is number one, hematogenous spread. Number two, there is organ involvement. And number three, chronic inflammation. So what is the common roots? It usually happens secondary to pulmonary tuberculosis. So it is going to start from hematogenous spread disseminating via the bloodstream. Now here it is important to remember that first of all, the cortex is going to get involved. Okay, the renal parenchyma, that is the cortex, is involved first. And after that, it can even remain dormant or it can remain active depending on the host immunity. So very simple, cortex is involved, then medulla is involved. And after that, you see, the collecting system is also getting involved. So cortex, medulla, collecting system. And the collecting system, the process starts at the level of glomerular capillaries. So here it starts at the level of glomeruli. And slowly it is going to involve the different parts of the collecting system. That is the minor calyx, then your major calyx, and then your pelvis. Okay. So we have a lot of great anatomy illustrations coming next. We'll understand how the disease spreads and the entire etiopathogenesis with the help of diagram. Okay. So in organs, we need to remember that genitourinary tuberculosis, in certain articles, it's considered the second most common form of TB after pulmonary tuberculosis, and different routes of dissemination include hematogenous, lymphatic, and sometimes direct organ spread. Now, chronic inflammation, you need to remember in TB, there's just a simple trick you can remember. In the initial stages, it is GC, and in the later stages, it is FC. So initial stages where the G is going to stand for the granulomas. Mostly these are caseating. So granulomas. Caseating granulomas are very prone to cavitate. So another C here is cavitate. Granulomas, which may be caseating mostly, sometimes non-caseating. When these granulomas are cavitate, so GC is granuloma and cavitation. And later on, F is of course for fibrosis and calcification. So F is going to stand for fibrosis and C is going to stand for calcifications. Okay. So we'll keep coming to this again and again and again. Right. Now this is taken from different articles of radiology. This one is from your RSNA article. So it is just illustrating that when you talk about the genitourinary system, there's no audio. Can't you hear me? Just let me know in the chat if I'm audible or not. Can other guys hear? How's the audio?
Audible, ma'am.
Audible? So, okay. So, option is Fego, please disconnect and connect again. There may be some lag at your end. Okay. So what is the myriad of findings? We have to see it is renal tuberculosis. In renal also, there is one thing, that is the renal parenchyma, as we discussed. So in renal parenchyma comes the cortex and the medulla. So just remember the cortex and the medulla, that is a part of the renal parenchyma. After that comes your collecting system, that is your PCS, the pelvic-calycial system. So here in the pelvic-calycial system, the disease process is going to involve your fornix, which is part of the minor calyx, and then infundibular. We'll come to that. I'm just telling you the names of things. So PC involvement, the most early, the most benign kind of process when it is just starting, it will start with the fornix. Okay. And it will go on to cause infundibular stenosis. Then it will cause caliectasis, which will be very uneven, irregular, asymmetric type of caliectasis. In the late stages, the ureter is also involved, and because of that, there is always in the late stages a component of hydronephrosis plus minus hydroureteronephrosis. So one is your renal parenchyma. In the cortex, in the medulla, there is going to be GC, that means granuloma, which can also form cavities, and later the cavities may be abscesses also, tubercular abscesses. So GC granuloma, which can be mostly caseating granuloma. Number 2C is cavitation. And number 3, there can be abscess formation at times if the host is immunocompromised. Okay, so that is the GC, which is in the renal parenchyma. In the collecting system, we'll come to all the different myriad of findings. After that, we need to remember the adrenal glands. So adrenal glands can also get involved. There is a type of miliary pattern of tuberculosis which have a predilection to cause adrenal involvement also. So miliary renal TB can cause adrenal involvement. Okay. Ureters, as we discussed, then comes your bladder. Okay. And after that is your urethra. Fine. Now, to understand all what's happening, I would say one of the most important diagrams of the entire class is going to be this diagram. Okay. So, level collecting system of the kidney, the microanatomy. Right. So be very curious whenever they hear the term papillary necrosis. It is the cornerstone of TB at the microscopic level. Okay. So they say high opsonized figure. So nothing, we have just discussed that TB can involve various things, the genitourinary system, the adrenal glands, all of that is the mediate of findings. And the diagram which we showed was from an RSNA article. Now we are discussing the microanatomy of the collecting system. Okay. So there is a term that is papillary necrosis. So it's a quick question to you guys. What do you think? The papilla is a part of what? Is it a part of the collecting system or is it a part of the parenchyma? And if parenchyma, what part of the parenchyma is the papilla a part of? Okay, so your question is, papilla is a part of what? What is the papilla exactly? Number two, your question would be, what is the fornix after that? It's a part of what? Okay, so these are two quick questions. Come on. The more you participate, the more you retain. So papilla is what, and it's a part of which structure basically, and then comes your fornix. Let's see what you guys have come up. So papilla, guys, is a part of, yeah, so papilla is a part of the parenchyma and fornix is a part of the collecting system, that is the minor calyx. Okay, so this is how you have to imagine this. The minor calyces are just related to the medullary pyramids. Okay, so like this is the minor calyx and these are related to the medullary pyramids. It's my medullary pyramid. Okay, so this tip region of the medullary pyramid, this is the papilla which is in contact with the minor calyx. It is the papilla through which collecting tubules, they have the urine coming from the collecting tubules at the level of papilla, which makes the transition from medulla into the calyx. So medulla into the calyx, that transition point, which is a part of the medulla, the apex, the last tip of medulla is going to be the papilla, which is in close contact with the collecting system, that is the calyx. Okay. So this is going to be my papilla. Medullary pyramid ka this tip region is going to be my papilla. Okay. And then collecting system. So collecting system, it appears like this. It is convex. So these two projections which are coming. Okay. So centrally there is a bit of an excavation. There is a concavity which is normal. And on the laterally there are two small horn-like structures and these horns are called as the fornix. This is also the fornix. So fornix, without a doubt, is going to be part of the collecting system. That is a minor calyx to be precise. Papilla is a tip of the medullary pyramid. It is like a transition point where urine is draining from the medulla to the loop of Henle through the collecting ducts into the minor calyx. So in the initial stages, it is this level of papilla where necrosis starts. So it's important to understand this thing first of all. Okay. Now, the next thing that people don't get, what is this infundibulum? Another frequent doubt comes is the infundibulum. Anyone knows? You can answer whatever. If you know, then just answer, be active. Okay. So infundibulum is that structure which is going to connect the minor calyx to the major calyx. Okay. So these are the minor calyx. This is minor calyx. This is minor calyx. This is also minor calyx. The structure which is connecting minor to major calyx, is going to be the infundibulum. So when we will say that there is infundibular stenosis or infundibular stricture, that means the outlet of minor calyx is blocked. So proximal upstream, there is going to be a lot of calyceal dilatation. So it is the outlet from minor calyx coalescing to form the major calyx via the infundibulum. So of course, infundibulum is also a part of the collecting system. Minor to major, in entry point from minor to the major calyx is going to be the infundibulum. So from minor calyx all the way to the major calyx is via the infundibulum. So this is very important. You'll hear these terms a lot: infundibular stenosis, infundibular strictures. We'll come to that. Okay, so I hope these three structures are very clear. What's papilla? It's a part of the medullary pyramid. It's a